Hey everyone, it's Nurse Sarah, and in this video, I'm going to go over some practice Med-Surg respiratory questions to help you prepare for the NCLEX exam. Our first question says, you're caring for a patient with pneumonia. The patient has just started treatment for pneumonia and is still experiencing hypoxemia. You know that respiratory acidosis is common with pneumonia. Which arterial blood gas reading below represents uncompensated respiratory acidosis? So in our multiple choice options, we are given a bunch of arterial blood gas results, and we've got to determine which results or which option represents respiratory acidosis uncompensated. So you could do this question a number of ways. You could go through and solve each of those options to determine which one's respiratory acidosis uncompensated. You could use either the tic-tac-toe method or the row method. I have an ABG workbook up here if you need extra help with doing these type of problems. Or you can do it this way, which is a whole lot faster because, you know, these tests are timed and we've got to keep up the pace. So how you can easily do this question is you got to go back and think back to normal results for pH, PaCO2, our carbon dioxide, and our bicarb HCO3. So let's quickly review that. A normal blood pH is about 7.35 to 7.45. A normal PaCO2 is 35 to 45, and then a normal bicarb is about 22 to 26. So we're looking for something that is acidic. Let's concentrate on that pH first. So we want to go ahead and just eliminate the options where the pH is either alkalotic or it's normal, meaning we probably have full compensation. So we're going to go ahead and eliminate option B because our pH is 7.48. That is on the alkalotic side because it's greater than 7.45. And then we're going to eliminate option D because the pH is 7.55 and that is definitely alkalotic as well. So we're going to mark that off. So we're left with options A and C. So option A, pH is 7.29. We know that is acidic, so we're somewhere in the acid realm. So let's go over and look at the PaCO2. It's 55. A normal is 35 to 45. Anything greater than 45 is going to be acid. So I'm seeing that my pH and my PaCO2 are both acidic. So let's look at our bicarb. Let's see where it's at. Is it normal? Because if it was, it would be uncompensated. Or is it abnormal? What is it? So it's 23. A normal is about 22 to 26. So that is normal. So right there, that value is respiratory acidosis uncompensated. But let's go make sure we're okay with C before we just answer. Okay, C, pH is 7.20. That's acidic definitely. What's our PaCO2? It's 50. That is acidic as well because anything greater than 45 is acidic. So that's looking very similar as as A. But let's look at that bicarb. What is it? It's 22 to 26. That is abnormal. So that right there is respiratory acidosis with some partial compensation. Our bicarb system is trying to increase that blood pH by making itself more alkalotic, but it hasn't achieved it completely yet because our pH is still on the acid side, so we don't have full compensation. So our answer is A. This question says, while helping a patient with a chest tube reposition in the bed, the chest tube becomes dislodged. What is your immediate nursing intervention? Here our patient has a chest tube, and unfortunately we had an accident. That chest tube has came out, which, you know, sometimes unfortunately happens in the clinical setting. So you need to know what you got to do for this patient because this is an emergency situation. Let's look at our options. A, stay with the patient and monitor their vital signs while another nurse notifies the healthcare provider. Okay, that sounds okay. I feel like we need to do a little bit more besides just staying there and just monitoring their vital signs. We need some more action going on, and of course we need to get help to notify the healthcare provider. But let's look at our other options. B, place a sterile occlusive dressing over the site and tape it on 3 sides and notify the healthcare provider. That looks a little bit better because we're actually doing something, and I like that than option A. But let's just look at the other options and then we'll go back and see which ones are better. C, attempt to reinsert the tube. No, you can eliminate this one right off the bat because that is out of the scope of practice of a nurse. We do not insert chest tubes. So mark that off. And then D, keep the site open to air and notify the healthcare provider. Well, for a second, you might think, okay, well, maybe, but let's think back to chest tubes. Chest tubes, we're dealing with the lungs and they're very sensitive to pressure. And so we don't want to keep this like hole open on the chest and just allow air to come in and mess with the pressures in our chest, because number one, that could cause further damage, and then number two, we're introducing infection possibly into that normal sterile space. So D, no. So option B is looking like our best answer compared to the other option. We're sort of thinking about option A, and let's talk about why option B I think is the correct answer. Well, it's telling us that we're going to put a sterile occlusive dressing and tape it on 3 sides where our chest tube has came out. And we want to do that because that's going to prevent more air from getting in that space, which we don't want. It's like going to be a temporary fix until we can get the healthcare provider there so they can reinsert another chest tube or do whatever they want to do. Now, as a side note, anytime you have a patient who has a chest tube, you want to plan for the future or those unfortunate dislodgements or break in the system or anything that can happen, because if it can go wrong, it's definitely going to go wrong, and it's going to go wrong when you're having a crazy day. So always keep these emergency things close by, like for instance, this sterile occlusive dressing and the tape in case this does happen, so you don't have to be scrambling and having to call supply and get your supplies for this situation. So we're going to do that. And also you're going to incorporate option A into it, of course, but here the answer is B, but you're going to get help from another nurse and get them to call the healthcare provider while you're staying there with the patient, monitoring their vital signs and looking for any respiratory distress. Here we have a patient with severe COPD, and they are having an episode of extreme shortness of breath and requests their inhaler. Which type of inhaler ordered by the physician would provide the fastest relief for the patient based on this particular situation? Here we have a patient who has severe COPD. So let's quickly recap about what this is. COPD stands for chronic obstructive pulmonary disease. And in a nutshell, what happens is that we have this chronic inflammation that has affected the lungs over time. And it's led to the airways being damaged, like the bronchial tubes and the alveoli sacs. And because of this, it's going to obstruct airflow. And patients can have various cases where they have just a mild case or they have an extreme case. And you're going to see like a chronic coughing with this, wheezing, and difficulty breathing like with exertion. Or I've even seen some cases where patients have had COPD so bad that even just talking, they can only talk a couple words and then they have to stop and take breaths and then they can talk a little bit more. So just even talking is really hard on some of these patients. So in this scenario, we're told that our patient is having an episode of extreme shortness of breath. So we have some emergency situation going on where we need to get airflow moving because this patient is not breathing really well. So we're giving these medications and we need to pick the medication that's going to provide the fastest relief. Therefore, whenever you are studying, like in pharmacology, these types of medications that are used for pulmonary diseases, you need to be paying attention to if they're like a long-acting or short-acting bronchodilator. Like how fast does it work? When do they take this? Because treatment is going to be based on what's going on with your patient and what type of inhaler they need. So our first option, A, it says tiotropium bromide. The brand name for this is Spiriva, which is a lot easier to say than that generic name. And this medication is a long-term preventative bronchodilator. So this is used to prevent bronchospasms. Right now our patient is probably having one. So we need something that's going to work immediately. So we can rule that one out. And then B, salmeterol. Salmeterol is a bronchodilator, but you got to determine is it short or long acting. And this is one of those long acting ones. It's also used as preventative and maintenance of lung diseases. It's not used for a rescue situation, so we can eliminate that one. Then we have option C, which is budesonide with formoterol. This is an inhaler that has 2 different types of drugs in it. The budesonide is the corticosteroid and the formoterol is the bronchodilator. bronchodilator, and this is part of that long-acting class. So again, that's going to be for the maintenance of our signs and symptoms. But that corticosteroid is also going to help maintain our signs and symptoms, keep those decreased, because it's going to decrease inflammation in our lungs. However, it's not really good for what's going on in this current situation, so we're going to mark that off. Therefore, we're just left with option D, which must be our answer. But why is it our answer? So albuterol is a short-acting bronchodilator. It works as a beta-2 agonist. So in your lungs, you have beta-2 receptors, and what this handy little medication does, once you inhale it, it goes and binds to those receptors in the lungs, because those receptors are on the smooth muscles, which control the opening and closing of your airways, which in this situation, our patient is bronchoconstricting, and we need to bronchodilate them. So we need to go in there and get on those beta-2 receptors so we can get on that smooth muscle and open it up so we can get some airflow going in. And that's what albuterol is going to do, and it's going to do it pretty fast. So this is our best option for a patient. Here we have a patient that we're educating on how to use a peak flow meter to help monitor the status of their asthma. Which statement by the patient demonstrates they understand how to use this device? So to answer this question, we need to select the option or the patient statement that tells us that the patient truly understands what a peak flow meter is. So in other words, we are eliminating options that are incorrectly said by the patient. So A, this device will make my lungs stronger so I don't have another asthma attack. Okay, whenever I read that, it makes me think that the patient thinks that by using this device, they are going to be improving their lung function. It's going to make their lungs stronger. So they're sort of confusing the peak flow meter with an incentive spirometer. And those are two handheld devices. They're both really handy, but they both have different goals. A peak flow meter is used to really monitor a patient's asthma, because it's going to tell us how well air is flowing out of their lungs, because this device helps a patient measure the highest amount of air that they can exhale out of the lungs. So it's looking at that peak expiratory flow. So by measuring that, that tells us if the patient might have narrowing in their lungs. So they have their goal, where they're at with, their highest reading they've got on this peak flow meter. So if they're using this regularly throughout the day like they should, and they notice that that percentage is going down, well, that tells us that there's less air being able to come out of the lungs, which tells us that we have narrowing and the asthma is worsening. So the patient can adjust their medication regimen based on this treatment plan that they've created with their healthcare provider, depending on the numbers that they're getting with their peak flow meter. So option A, we're going to eliminate that one. B, I will exhale as hard as I can while using this device. Okay, well, whenever you're using the peak flow meter, that's what you do. You don't inhale on the device, you're breathing out, because we're measuring the airflow out of the lungs. So option B is looking good. C, I will lie down when I use this device. No, that's not right. Whenever you use the peak flow meter, you're not going to be lying down while you're doing it. You're going to be standing up and blowing on this device. So we can eliminate that one. And then D, I will notify the doctor if my peak flow rating is 90% or more than my personal best peak flow. So with this, you've got to be familiar where the patient should be in these readings. So here on your screen, you can see where we want the patients. There's different colored zones, and based on what zone the patient's in will depend on what they're going to do. So for instance, the green zone, we have an 80 to 100% of their readings that they've got. If they get this, this is great, and we know that green means go, it's good. So they're going to continue with their normal medications. They have good lung function and control at the moment. Now let's say it's less than 80%. They're in that yellow zone, so we're a little cautious here. That tells us that, hey, not much air, it's decreased about how much is flowing out, so your asthma is getting a little worse. So you want to follow the medication treatment plan that you've made with your healthcare provider to prevent an attack from coming on. And then the absolute worst they can get is less than 50%. That means they are in the red. Red is bad. So they're in the red zone, and if that's the case, they need to go and get medical care so we can give them some treatments to prevent a asthma attack from coming on. So our best answer is B. Next question says you're educating a patient with COPD on how to deep breathe by using an incentive spirometer. Which of the following is the correct way to use this device? So now we're dealing with an incentive spirometer instead of our peak flow meter. So the incentive spirometer, we like to give patients who are going to be having surgery with this because it can help prevent pneumonia. Also, it's a great device for patients who have breathing disorders like COPD because it helps keep their lung function stronger and it helps clear the airway. So option A, encourage the patient to use it twice a day. So twice a day, that's not a lot. You need to be using this device at least 10 times every 1 to 2 hours while awake. So, if they're sleeping, they don't need to get up and do it. But while they're awake, they need to be using it at least 10 times every 1 to 2 hours. So we can be popping those lungs open, moving those secretions, making sure we're not decreasing our lung function. So we're going to eliminate that one. B, the patient exhales into the device rapidly and then coughs. Okay, so I know with the peak flow meter we talked about you're exhaling in the device. So with an incentive spirometer, you're doing the opposite. Instead, we are inhaling on the device. Here on your screen, I want you to look at these steps on how to use an incentive spirometer. So first, depending on what kind of device you have, you're going to attach that flexible tubing to the port. And then you want to set the goal for the patient with a marker of any kind that's on the device because that lets the patient know where they've got to go. And then, you have the patient set up and exhale completely. And then they want to seal their lips around that mouthpiece tightly. And then have the patient inhale deep and slowly. So we're inhaling, we're not exhaling, and making sure to keep the yellow indicator within normal range. You don't want them doing this too fast or too slow, and this piston is going to rise. Now, the patient needs to keep inhaling as deep as possible until unable to hold their breath any longer, and then hold breath for 6 seconds. Then after that, exhale slowly and allow the piston to fall and then repeat again. So we can eliminate B. And then C says patient inhales slowly from the device until no longer able and then holds breath for 6 seconds and exhales. And that looks pretty good, pretty promising. That's like what the steps were that we went over. But let's take a look at D. The patient rapidly inhales 10 times from the device and then exhales for 6 seconds. This is not correct because we need to make sure that the patient is using this device slowly until they're no longer able. They just don't rapidly pull or suck on this device. And what's interesting is that a lot of times whenever you give patients these incentive spirometers, you have to take time to educate them, because I've had patients, whenever they're about to use it, I've seen them rapidly inhale on the device. It's almost like that's what you naturally think you need to do. And then I've also seen where patients will try to blow in the device. Of course, it's not going to work whenever they do that. And then another problem I've seen is that they just don't use it as often as they need to, or they're not using the device in sets of 10. So they're not using it really long enough. So our best answer for this question is C. Next, we have a patient who is recovering from a pneumothorax and has a chest tube present. Which of the following is an appropriate finding when assessing the chest tube drainage system? So our options say the following. We have A, intermittent bubbling may be noted in the water seal chamber. So let's think about this for a moment. It tells us that there's intermittent bubbling. What does intermittent mean? That means it's happening occasionally, here and there. It doesn't say it's continuously happening, which means it's happening constantly. That if it did, that would be troublesome because we may have a leak and we need to investigate that, but it's intermittent. So whenever you're seeing this bubbling, you want to ask yourself, okay, why does my patient have a chest tube again? And we're told that the reason they have one is because they have a pneumothorax. And remember, a pneumothorax is where air has got inside that pleural space and shouldn't have been there, and it's caused our lung to collapse. So in a nutshell, what's going to happen is that they get this chest tube that's going to help relieve or take out that air that is there and hopefully help our lung re-expand. So in our chest tube, what is going to be coming out of that tube if they have a pneumothorax? Mainly air. So it's just going to be natural that you're going to see this intermittent bubbling here in this water seal chamber. So that option looks possibly like an appropriate finding, but let's look at our other ones. B, 200 mLs of drainage per hour is expected during recovery of a pneumothorax. Well, that's quite a bit, and the fact that our patient has a pneumothorax, they really shouldn't have that much drainage. And if they're having 200 mLs per hour, that tells me that something else may be going on. Maybe they have some more damage in there and we need to investigate that. So that wouldn't be inappropriate. We'll mark that off. C, the chest tube drainage system is positioned at the patient's chest level to facilitate drainage. With this, you want to remember how you should position the drainage system of the chest tube. It's going to be assisted with gravity and draining out what it needs to drain out. So we do that with gravity. So it's best to place that drainage system below the patient's chest. So that's not an appropriate finding, so we'll mark that off. And then D, that makes our job easy. All these options are appropriate findings, and we just figured out that B and C weren't, so D's not the answer, so A is our answer. Here we're told we have a patient who has exercise-induced asthma. Which of the following actions can the patient perform to prevent an attack during exercise? Select all that apply, so we're gonna have multiple answers. Option A says avoid warming up before exercise. So is this something that a person who has a history of exercise-induced asthma would want to do? Would they want to avoid warming up before the exercise? The answer to that would be no, because they need to get their body acclimated or prepared for what is about to happen, especially prepping those airways. So doing some little short warm-ups will help prepare the lungs for their exercise instead of shocking them. So we're just going to X that one out. Option B says administer a short-acting beta agonist before exercise. So is this something they would want to do? Well, let's think about this. Short-acting beta agonist is going to work really fast. They can use it right before the exercise, anywhere between 10 minutes, 30 minutes. And what it's going to do is it's going to go ahead and prep those airways and get those nice and dilated. So whenever they go to exercise, which could, cause some bronchoconstriction, we've already have that bronchodilator in there to prevent those signs and symptoms from coming on. Because depending on what medication they're using, these bronchodilators can last up to 4 hours, which gives them plenty of time to do their exercise regimen. So yes, this can definitely be something that a patient with exercise-induced asthma can do. Now, as a side note, short-acting beta agonists, the rapid-acting inhalers can be used, but patients could also use one of those ones that we talked about earlier, like Symbicort, where we have the combination of budesonide and formoterol, where they take that beforehand to prevent that. So just keep that as a side note as well. And then option C says administer a short-acting beta agonist after exercise. No, it's best to do it beforehand. So we have that dilation before we exercise, because exercise, hence exercise-induced asthma, that's what's causing our asthma. So we want that on board before we actually do it. So it wouldn't be after. And then D, avoiding exercise when experiencing a respiratory illness. Yes, we'd want to educate and tell them about this, because whenever you have something going on with your lungs, they're compromised, they're definitely at risk for experiencing bronchoconstriction. So we want them to just fully recover before they go and exercise. Our next question says, a 52-year-old female patient is receiving medical treatment for a possible tuberculosis infection. The patient is a U.S. resident but grew up in a foreign country. She reports that as a child she received the BCG vaccine, which is the Bacillus calmette-guerin vaccine. Which order by the healthcare provider below would require the nurse to ask for clarification? So whenever we're looking at these options, we're looking for an option that really jumps out at us that wouldn't be something that would be good to be ordered on this patient. So we see that the patient has had the BCG vaccine. That's one thing that should be jumping out at you. And we're testing them for possible tuberculosis infection. So option A is a PPD test, which is a MAN2 test. That is the skin test for tuberculosis. PPD stands for Purified Protein Derivative. That's where you get the little injections on your skin, and we're looking for a positive result. B, a chest x-ray. C, an interferon gamma release assay, which is an IGRA, which is a blood test that tests for tuberculosis. Or D, a sputum culture. So which one makes our nursing bells go off and says, hey, this probably isn't the best test for this patient to help us look for tuberculosis? Okay, so let's talk about this BCG vaccine. This is a vaccine given in foreign countries. It's not given here in the US. It's given to pediatric patients to help prevent a tuberculosis infection in areas where tuberculosis is very high. Now, because they're getting a vaccine, they're being exposed to this bacteria. If we go and do a skin test on them, the PPD, what do you think is going to happen? They're probably going to have a false positive. So that's not the best test for them, the MAN2 test. However, what would be a little bit better for them? Would it be a chest x-ray, the IGRA, or the sputum culture? A better option for them would be the blood test, so just testing their blood for it. However, this question wants to know which one will require a clarification, and the answer would be A, the PPD. Next, we have a patient who's had a PPD skin test, again, that MAN2 test. As the nurse, you tell the patient to report back to the office so we have a drop-down box, and it says 24 hours to 48 hours, 12 to 24 hours, 48 to 72 hours, or 24 to 72 hours. So the results can be interpreted. So with this, you just got to pull from your memory bank and you got to think back to when a patient should come back to get their reading read. And the answer is 48 to 72 hours. They have to come back within that time frame, not before or not after, because if they come before, it's way too early, we can't interpret it. If they come after, they're just going to have to redo the test because that's when the results pop up. Our next question says a patient is on mechanical ventilation with PEEP, which stands for positive in expiratory pressure. Which finding below indicates a patient is developing a complication related to their therapy and requires immediate treatment? So to answer this question, we're looking for something that jumps out at us that tells us they're developing a problem related to this mechanical ventilation with PEEP. So a bicarb of 26. Normal bicarb is 22 to about 26. That's within range, not too concerned about it, so we're good with that. B, a blood pressure of 70/45. That's concerning. That is hypotensive. Now, is that a problem? And let's talk about it for a second with PEEP. Okay, so PEEP is a setting on the ventilator, and in a nutshell, what it is that we're keeping this small amount of pressure in there, especially during expiration, so those alveoli sacs are just staying open a little bit more. So we can have better gas exchange where oxygen is going into that bloodstream and carbon dioxide is going out. But the problem is that we can overinflate these lungs. And so whenever we do that, we could cause a pneumothorax. We could cause subacute emphysema where air starts to actually escape from the lungs and go into our subacute tissue. Or we can cause another big problem, which is probably what's going on with this situation, where we've increased intrathoracic pressure inside the chest. So in your chest, you have your lungs, but what's next door? Your heart. So if we've increased the pressure on those lungs, on that heart, we're affecting how that heart can pump. So it can't fully contract and expand. And we're going to affect how it can actually fill with blood and pump that blood out. So when we do that, are you pumping out a lot of blood throughout your heart? No, you're going to drop your cardiac output. When we drop cardiac output, one of the things that you can see is that their blood pressure will drop. So that is very concerning. So I'm going to keep B in the back of our mind. C, a PaO2 of 80, how much oxygen's in their arterial blood. That's within range, about 80 to 100, so we're okay with that. D, a PaCO2, this is our carbon dioxide in our blood. We don't want too much or too little. About 35 to 45s are normal and they're within that range. So our answer is B. Next, we're told the healthcare provider orders chest physiotherapy on your patient with cystic fibrosis. This is best performed when? So just to recap, cystic fibrosis is a genetic disorder that is caused by a mutated gene, the CFTR gene. So we have an issue with our CFTR protein. And because we have an issue with this, we have problems with creating this thick, sticky mucus that affects not only our respiratory system, but our digestive system, particularly the pancreas. So with this, patients have to get chest physiotherapy. And this is like a combination of percussion, vibration, deep breathing, and expelling mucus, clearing those airways. And they have to do this regularly. So as the nurse, you need to know when this should be best performed. So we have A, immediately after a meal. Okay, so whenever you eat food, your belly's full, and is this a good time to have percussion and vibration and coughing and spitting up? No, because doing that can increase the risk of aspirating and vomiting because you have a full stomach. So we would not want to do this immediately after a meal. B, right before a meal. Think about the patient. They're about to eat a meal, they're hungry, but do they just want to have been going through percussion, coughing, deep breathing, getting the sticky mucus up and have that in their mouth and then go eating right to a meal? It's not going to be that pleasant, so it's probably not best before a meal. So we're going to X that out. C, 1 to 2 hours after a meal. Okay, 1 to 2 hours after a meal, our food has been able to leave our stomach by then. It's making its way through the intestines, so we should have relieved the pressure in there. We're full, we've already ate, good. So yes, that would be probably the best time to perform this. And then D, only at bedtime. No, because this is not something that's just performed at bedtime. They're going to do this multiple times throughout the day. So our answer would be C. Okay, so that wraps up this review over practice Med-Surg respiratory questions. Now I also have other reviews where I go over other types of questions. So if you want to access those, you can get it in the link below.